So I knew that I always had an interest and a passion for neurology, but I suppose I was still a rotating grade one at the time. And it was very much, I had the attitude of treat what you see, essentially. Beforehand, I would pull up the brain scans just to see if I could identify what was flagged on the radiological report, if anything, beforehand. I wouldn't know what I was looking at. If there was a CT, I'd usually just pull up the most obvious looking CT, scroll through it, scroll up and down and go, cool, there's a brain. Great. Okay. It's not changed at all what I'm going to actually do in terms of my assessment or treatment. I just wanted to see the brain scan to say that I've seen it. And now I'm going to go assess the patient and, again, assess everything and essentially treat what I see. So beforehand, I felt like even like my diagnostic and prognostic skills and trying to gather information beforehand to try and get a picture of what the patient was like, it was pretty much non-existent beforehand. It was very much read the file, look at the brain scan, but still approach every assessment the same way, where you'll essentially go through every possible impairment-based assessment and go from there, essentially. So I felt like it was very non-specific, it wasn't individualized, and it was more time-consuming as well, because I didn't go in with an expectation of what the clinical picture would be like, essentially. I just walk in and go, okay, again, assess what I need to assess and treat what I see. Because I didn't have an expectation or a clinical picture of what this patient would actually present like, I didn't know or expect what their symptoms might be based on, wherever their stroke or lesion happened to be. The clinical decision making as well was usually difficult, in that now when I see the patient, I can sort of have a rough idea as to what kind of impairments they have and where they might go in terms of discharge destinations. Beforehand, I didn't have any kind of idea. So it was really a matter of seeing the patient and making some clinical decision making on the spot, which as a junior and without the brain imaging, it often took me a little bit more time and thinking. I wasn't as confident with my clinical decision making. I'd often sometimes need to go to either another discipline or my seniors and go, this is what I'm thinking, this is what I'm assessed. I'm not sure though, have you found similar type of assessments, either with similar kind of patient populations or with this patient if they've actually assessed them as well? So again, it was just sort of non-specific, not individualized, general, and very time consuming, because it took me a long time to figure out exactly what I'm dealing with. Prior to hearing about your courses, I hadn't really done anything to upskill myself in brain imaging specifically, because I had the preconceived notion that it's not a physiotherapist's role. Our role is pretty much to maybe understand what the report says, maybe to be able to see where the lesion is. But aside from that, essentially it's just another tool, or like just another thing to look at before you actually go and assess the patient, right? So beforehand, I hadn't, besides essentially looking at the scans, maybe with a doctor or somebody else next to me pointing things out if they had more knowledge than me, that was about the extent of what I'd look at in terms of my brain imaging and what I felt that we needed to do in terms of brain imaging beforehand. I really didn't think it was possible or a responsibility of rehabilitation clinicians to be able to look at a brain scan, interpret it differently to how the radiologists and the medical team do, extract information from it, and tailor your assessment and treatment to it. I didn't even know that was a possibility beforehand.
Right.
I appreciated like radiological investigations beforehand, in the sense that I was rotating around and I'd done a lot of cardiorespiratory stuff. So I looked at chest x-rays all the time. But aside from that, it was one of those things that with brain imaging specifically, and even other types of radiological investigations, I'd look to say that I'd done my due diligence of looking at the image, And that was about it. Again, it wouldn't necessarily change my assessment or treatment or anything like that. I guess one of the first things I realized is that it is our role and responsibility to be able to understand the images, look at the images, and extract our own kind of rehabilitation information out of it. Because, like you always point out, the reports and the reasons for getting the investigations are usually diagnostic and prognostic, and they're usually to answer a specific question the doctors are asking. It's not tailored for rehabilitation clinicians like ourselves, essentially. So, one of the first things it did is empowered me to actually be like, oh, I can actually look at this scan. And even if the report doesn't have the specific information that I need, I now have the capability and the skills to be able to look at it and extract specific information from it. So that was number one, is that it empowered me to actually have an additional diagnostic and prognostic tool to use. Two, I think, is that it really helped with my neuroanatomical skills and um, knowing what brain functions actually were and how to translate that again into assessment and treatment. It was one of those things beforehand that whilst we'd gone through neuroanatomy at university, like what you always point out, I knew what it was like in a 3D structure, but then when you translate that to 2D images going up and down, and even just basic things like learning how to use the program of whatever the image is relayed on, that was quite a challenge beforehand. And afterwards, I felt confident enough to be able to use them, extract specific information about where the lesion is, how it might present clinically, how you can tailor your assessment and your treatment as well, in order to individualize the patient care and make it patient-centered. That was really quite empowering as well. I'm certainly still learning and still honing those skills. So, like any kind of skill, the more I practice it and the more I utilize it with patients, the better I get. But it's certainly just given me a lot more confidence as well in regards to being specific with my assessment, treatment, and providing the education and maybe not specific prognosis, but generalized idea of how a person might recover. It's just given me that confidence as well. And I think that has also translated into my clinical practice, where I think my patients also feel more confident with me as a clinician as well, because I have additional tools to be able to talk about recovery. I do actually. Um, Obviously, if a brain scan has shown something. But yes, I mention it all the time. The only time I think I won't describe what has been shown in the brain scan is if the doctors have not originally had that discussion. So if I see someone who's just had an MRI saying it does show something, I'll let the doctors have that discussion first about it's confirmed a stroke, and then I'll go back in and reiterate that essentially. So I talk about it quite a lot. I give people the opportunity to look at their brain scans, and more often than not, it's actually the family that want to see it. They want to get an idea of how big or small it is, where it is, even just like what the generalized brain looks like. Um, so I do quite often use brain imaging in regards to explaining specifically what the impairments are, how they can recover from it, and what their generalized prognosis is from the brain scans. Say, for instance, just or the day before yesterday, I had a patient who had an established occipital infarct, on their MRI brain scan. So knowing that, at least and I had a student at the time as well. So we sort of went through the brain scan, and I was able to break it down with the student and say, okay, so first of all, where is the lesion? Occipital lobe. What does the occipital lobe do? Primarily vision. Okay. According to that, what do we expect in terms of an impairment-based strength assessment? What do we expect in terms of a sensory assessment? What do we expect in terms of a cognitive assessment, etc.? So we were able to sort of go down the impairment list of what we would potentially assess if we didn't have that established brain scan, we didn't have that preconceived knowledge. And we were able to sort of clinically reason with my student that essentially we should hone in our assessment primarily on vision, and just screen the other impairments, because that's essentially what the infarct and the brain scan shows. And if anything in our assessment does show something different, then maybe it's time that we go back and have an original look at the scan, essentially. So I suppose knowing what the clinical picture might look like with the actual patient has really helped me in regards to trying to speed up my assessment, be more specific with my assessment and treatment, and already before I even see the patient, have an idea as to what the discharge plan might be, what kind of follow-up they might need, what kind of education they might need, what kind of carer training, resources, possibly even like compensatory approaches if we need. It just gives me that much more clinical confidence as to what I'm actually going to do with the patient before I even set eyes on them, essentially. It's the brain imaging course has really helped me, I think, in terms of improving relationships with the doctors, because I now know what they're talking about whenever they talk about radiological investigations and scans. The doctors before I did, or before I even started at Northern, already had a weekly meeting with the neuroradiologist, with the radiologists, where they would sort of talk through some of the more complex scans about how it might change their overall management and diagnosis. And so after I did my brain imaging and I have provided some education to some of my other colleagues who are not within physiotherapy and other students as well, they were able to see that I was very keen and interested in brain imaging. So as a result, they've invited me along to the neuroradiology meeting, as well as the rest of the allied health colleagues as well, if they're interested. We're starting to look through scans more often. So say that, a scan is done and it's NAD and the doctors are looking through it. I will often jump in as well, have a look through, give my 2 cents, ask them questions about what they're seeing that I might not see. So I think overall it's really improved our relationship, and that the doctors can see that I've upskilled in this area and I know what I'm talking about for the most part in terms of assessment and treatment, not necessarily in terms of diagnosis and management plan, but I can see what they can see. And so thus we're able to have more clinically complex discussions. I'm able to understand more about when they have their neuroradiological meetings, what they're actually looking at, why it will change their management plans. And I guess ultimately it just means that we're a more collaborative team because we speak the same language, essentially, and when we're talking about brain scans. As well as that, because I've done the brain imaging and no one else in my acute setting has, oftentimes whenever I bring up brain scans to have a look at it and go through it with my student or grade one at the time, other people will come along and also have a look at the scan and ask questions about what are you seeing there? What's this thing? How do I read a scan? Or I've got a patient over here that I couldn't understand the report. Can we look at the scan together? So I think it's also made other clinicians who I work with aware that it can be a tool that we can use. And I think as a result, there's quite a few people that I work with that have also signed up for the brain imaging course as well. And I hope that in the future we'll be able to even have like meetings where we have case studies and go through specifics and essentially deepen everyone's knowledge within Northern Health so that we can utilize brain imaging more so that we get better clinical outcomes and better patient outcomes. I think where it has changed slightly is probably more in terms of diagnostics. So like the example that I've given previously with a patient who their diagnosis was functional neurological disorder, but the other clinicians sort of had queries about that and had doubts about that. So when I was able to go and have a look at the brain scan and pick up potential old strokes and things that were missed on the radiological report, they were able to put a little bit more credence into that, essentially, that they knew that I'm brain image trained. So it's not like I'm just having a look and questioning their decision without any kind of other clinical knowledge or information, essentially. So I think it's helped in regards to trying to have discussions about what are we actually dealing with here. So not necessarily in terms of treatment or discharge planning, but certainly in regards to diagnosis and subsequent best optimal management as a result from the diagnosis. It has really helped foster our relationships, and they certainly put more credence into what I have to say, essentially. And they're more than happy for me to not question them, but essentially raise possible questions, I suppose. I think it certainly made me feel a lot more confident in myself, a lot more confident in my clinical decision making, confident in my communication as well, in the sense that if if patients or other health professionals or doctors or anyone that I'm working with have queries or doubts about where I'm coming from in terms of my assessment and treatment, I feel like I've got an extra tool to be able to sort of bring up with my clinical knowledge and reasoning and say, this is why I think X, Y, and Z. If you have a look at the type of lesion and the type of penumbra that we've got associated with it, it just gives me that much more information to be confident in my, yeah, essentially acute clinical decision making. Because I do work in the acute side, and often I'm one of the first point of calls for people to have a stroke. Understandably, I'm the one that they ask a lot of questions to. Am I going to walk again? Am I going to get better? Am I going to get home? And whilst I'll always put a caveat of, it's I don't have a crystal ball. It's impossible to say with 100% certainty. It does give me the confidence to be able to at least give a rough prognosis in regards to, I think you'll be able to walk again. It's possible you might need a little bit of help down the track, but again, anything can happen. Neuroplasticity can be utilized any which way, right up until the day you die. So I think it's given me the ability to instill hope in patients as well. I think it also really helps provide a lot of, what's the word? Empowerment and reassurance to patients in the early acute days. Oftentimes, when they've had a stroke, it's a massive life-changing event for them there, and they're scared, they're uncertain, they don't know what the future will hold. And so, I think to be able to show them the brain scan, if it's appropriate and they want to see it, to explain why they're having their symptoms and to explain how it can be treated, also just gives them that much more assurance, um, confidence that we know what we're talking about, we will help you get better. I think it just really empowers patients in that acute side when they're very, very scared. And so I feel like it's also made me feel much more fulfilled as a clinician as well, because I know that I'm getting better clinical outcomes with my patients. One thing I will say actually that I forgot to mention before is one of the things that I really found quite empowering in the early days is when because I completed the course when I was still a rotating grade one, it was quite empowering to be able to pull up a scan and read it and actually have more knowledge and experience with brain imaging than some of my neurological seniors at the time who hadn't necessarily been privy to the fact that we can actually read the scans and pull different information out of it too. I think I'd asked them previously, like at a different working place and health network, have you heard of Etty's courses? Are you thinking of doing it sometime? And they sort of went, I don't really know what I'll get out of it. And I'm just very thankful that I did the course at the time, even if they haven't done it since, because I really feel like I've gained skills, which I don't think they'll be privy to if they don't do the course or any other kind of brain imaging upskilling, essentially. So that was really empowering at that point as well.